Hello, everyone, and thank you for joining this webinar. I've been asked to address the issue about whether autologous stem cell transplantation should still be considered for all transplant-eligible patients as upfront therapy for multiple myeloma. I think this is a very valid question, considering all the new treatments that have become available for multiple myeloma and that have been effective in the setting of relapsed refractory myeloma and the changes in induction treatment for myeloma. But I do think it's important to review the data, and I'm going to share some slides. You can see here, this is the IFM 2009 study. This was a randomized trial of modern induction therapy with a proteasome inhibitor, bortezomib, an IMiD, lenalidomide, and dexamethasone, versus without upfront transplant versus the same induction with consolidation with upfront transplant with high-dose melphalan 200 milligrams per meter squared. This trial was published in the New England Journal of Medicine and was recently updated now with almost 9 years of follow-up. So let's look at what the updated PFS shows. So what you can see here, that by 2 years, 1 out of 5 patients transplanted had already progressed. But in 8 years, and this is the French study, so they had no maintenance therapy, there was, 1 out of 4 patients remained in remission without transplant and off maintenance versus 1 out of 3. So and obviously that was reflected in a significant benefit in progression-free survival. Even patients who were MRD negative benefited from getting transplanted up front versus those that did not. Now, mind you, we also have to recognize that there is a proportion of patients who did not get transplanted who remain in remission without relapse, particularly if they're MRD negative. So you can see that MRD negative patients who did not get transplanted, there was about 50% of them have still in remission. So I have to admit that, it is a personal decision that now we have to discuss with patients. So you can imagine a 75-year-old who gets induction treatment and gets MRD negativity might not want to go to upfront transplant, particularly if they have standard risk disease. This is the determination trial. Again, this is lenalidomide until progression. And again, if you look at comparing upfront transplant versus upfront non-transplant, significant benefit for 5-year progression-free survival for patients who got transplanted, 55% versus 41%. Significant clinical benefit for the median PFS, 67 months versus 46 months. But there is a substantial proportion of patients who did not get transplanted up front, who are alive and in remission with only lenalidomide maintenance. So what am I telling my patients today? So what I'm telling my patients is we have a discussion, particularly patients with high-risk disease, regardless of their response to induction therapy, should undergo an autologous transplant and should actually be encouraged to participate in a clinical trial with novel maintenance therapies beyond lenalidomide maintenance alone. Patients who achieve a complete remission with MRD negativity after induction therapy, if they have standard risk disease, if they're older than 75 years of age, we have a conversation. If they're younger than 75, I generally encourage them to get transplanted because I think at the long end, the burden of treatment is significantly less because of the progression-free survival benefit. What happens with 4-drug inductions? I think with a 4-drug induction, the benefit of transplant will continue to be maintained because the MRD negativity rates will be higher, as we saw from the Griffin trial with sustained MRD negativity for patients who had 4-drug induction, autologous transplant was more than 37%. So with that, I end my discussion to say, when I'm asked, Dr. Giralt, do you still recommend transplant for all patients with myeloma? The answer is no. But I recommend it for most patients with myeloma who are transplant eligible. I do recommend it for all patients with myeloma who have high-risk disease, regardless of their response to induction therapy. And I recommend it for most patients, particularly if they're less than 75 years of age, with standard risk disease, regardless of their response to induction therapy. Thank you so much for your attention.